Okay, now pivoting to lesions of the spinal cord. All right, three major tracks we're looking at. Corticospinal, I think brain needs to plan movements. This has to do with motor. This is a descending pathway. This is over here. Dorsal column, it's the dorsal column of the spinal cord. It's the medial lemniscus when we get into the brainstem. I think of dolphins. Dolphins are very evolved and, they have fine touch and proprioception, all that fancy stuff. So this is proprioception, discriminatory touch, and as the name implies, it is in the dorsum. And the spinothalamic tract, I think of people get spine injuries, the first thing they say is, I can't feel my legs, right? Crude touch, pain, and temperature. This is right here on the anterior side. Decussation, all of these are going to have interesting crisscrosses, really important to get these. So the dorsal column and the corticospinal tract are similar in that they will both decussate at the medulla. That is to say, if I have a, like my right brain wants to tell my left arm to do something, there's the axon moving down the right part of my brain until it gets to the medulla. Then it crosses over. Now it's permanently on the left side until it gets to my left arm. And same thing, if my left arm is feeling a vibration, that is going to move up from my left arm up the left part of the spinal cord. It is going to decussate to the medulla, and then it's going to go to the right post central gyrus to relay that information. The spinothalamic, though, is different. The spinothalamic is, for the most part, going to, right where it comes into the dorsal part of the spinal cord, it is going to cross over at the anterior white commissura, right at that level, and then it's going to go up and forever stays on the other side. A little bit of an exception that it sometimes can escape through something called Lissauer's tract, where it can actually go up here 1 or 2 levels before decussating over. Crude is just, hey, can you feel it when I'm poking you or scratching you or whatever? Fine is like, oh, can you differentiate a poke there versus a poke there? Can you differentiate me poking there versus poking there? That's discriminatory touch. Motor neurons, we have upper motor neurons, which is just a 2-neuron system, so it's easy. Notice the decussation at the medulla. It's everything from the brain to this right here, to this anterior horn neuron soma. And then everything after that is just going to be the lower motor neuron. So blue, upper motor, red, lower. So if you have an upper, the brain is usually trying to tell the rest of the body, like, hey, cool it. You don't need to flex so much. You don't need to do the Babinski, stop. It's kind of a party pooper. It's a wet blanket, right? So if we have an upper motor neuron injury, it can't tell the rest of the body what to do. So the muscles just go crazy. The lower motor neurons are constantly firing. So everything is up in an upper motor neuron injury. We're going to have more reflexes. Our tone is going to go up because the muscles are contracting. We're going to have Babinski, is the foot is going to go up. It's the positive Babinski sign. Now, this is a little different now. The spasticity, it's called a clasp knife. So if you guys have ever opened a knife, it opens slowly, and then all sudden at once. Slowly. Sorry, my red is probably not helping. And then all at once. Same thing here. Look at this person. It's going to go slow, resistance, and then it goes, right? That is a clasp knife spasticity. It's upper motor neuron sign. No fasciculation. So a fasciculation is that the muscles are always, without any innervation, even from a lower motor neuron, the muscles are just going to twitch every now and then. So these are just random twitchings. So this sounds like it would be upper motor neuron, but no, this is actually a lower motor neuron. It's just random twitchings if there's no innervation. So we don't have these here. We do have this here. And as we said, there is the clasp knife. So I guess this is kind of redundant. Everything is down here. It's down because there's an atrophy. We're not using these. Babinskis are down, as they should be in any case, actually. And then we have a flaccid paralysis. So just spinal cord, if you have damage to the dorsal side, proprioception, it's going to have balance issues and fine touch. The thoracic region on the lateral side, we have these sympathetic columns, so you get like a Horner syndrome or any sort of sympathetic deficiency. Cortico, remember that's brain. We want to do movements, so this would be upper motor neuron. Really anything in the spinal cord for the most part, except for the anterior horn and the brain, is going to be upper motor neuron. Anything going from the anterior horn to the muscle is going to be lower motor neuron. That's then the anterior side of the cell bodies. Spinothalamic is also on the anterior side. This is pain, temperature, crude touch. Just can you feel this or not feel this? And the dorsal root ganglion is going to be for both the spinothalamic and the dorsal tract. And this is going to be for deep tendon reflexes too if this is damaged. So deep tendon reflex is like, let me bang on your knee with a hammer. And if your patellar reflex activates, that tells me that L3 is working. You should be familiar-ish with the dermatomes, the myotomes. We talked about this last time. And you're going to be a paraplegic if you have a lumbar injury, and a quadriplegic if you have some sort of cervical injury. You should know these reflexes as well. We'll go through them quick. C5 bicep, C7 triceps. L3 is going to be the patellar, and then L5S1 is going to be the Achilles. There's a little bit of overlap between a couple of these. All right, so these are really common, like syndromes, diseases, manifestations of, causes of spinal cord lesions. So we can really differentiate these with this Venn diagram and about which tracts are affected. So ALS is going, Lou Gehrig's disease, this is all motor. Polio, all motor. SMA, all motor. Friedreich ataxia, that's actually a little complicated. I think it's mostly motor. ASA is going to be a little bit of motor, a little bit of spinothalamic. B12 deficiency is mostly going to be proprioception and dorsal, but it's also a little bit of the motor neurons as well. Tabes dorsalis is like famously just proprioception in the dorsal column. Syringomyelia, this is, unless it gets really way huge in like the thoracic region, right, associated with Chiari type 1, this is going to be the just the spinothalamic. Maybe it's more reasonable that it gets to the lateral horns as well. And then Brown-Séquard is going to get all three of these. It's going to be a hemisection where it's just hitting kind of like one side of the spinal cord. All right, so let's start with the hard one, the Brown-Séquard. All right, so somebody hits us with a lightsaber right at this region right here. How can we figure out what's going to happen? Let's just start with, so there's our dead end, right? That's where we got stabbed. Corticospinal goes up, it crosses the medulla. What does that mean? That means that that tract has no way to get through that roadblock. So I cannot move any of the muscles of my lower right leg. And if these axon tracts can't move, that is going to be upper motor neuron signs. Notice that at the site of the lesion, we're actually damaging the ventral horn. So that is actually going to be a lower motor neuron sign right at the level of the vertebral level of the lesion. But for the most part, it's going to be upper motor neuron signs. All right, what about the dorsal column? That does the exact same pathway. It also crosses the medulla. So I'm also going to have issues with proprioception and vibration, discriminatory touch on that side. All right, what about the other side, right? Because remember that the spinothalamic crosses the anterior white commissure at the level where it enters the spinal cord on the dorsal side. So we won't be able to feel anything on the contralateral side in terms of pain or like temperature, just like crude touch. But notice that, wait a second, shouldn't this be affected? Because it's supposed to, the nerves that are going right here, shouldn't they cross right over? And, if they decussate at that level, shouldn't this also be affected? No, because remember, we have Lissauer's tract. It actually goes up one or two levels and then crosses. So it actually misses the dead end. So that's why you're going to have this like slight asymmetry in terms of like one or two vertebral levels up or down when you have the Brown-Séquard syndrome. ALS, upper and motor neuron degeneration, doesn't affect sensory at all. It's linked to a couple different gene mutations. One of them is in superoxide dismutase, so I guess there's just way too much oxidative stress and that damages certain cell bodies. No cure. It hits people in their like 40s or 50s and is a 5-year life expectancy. Quite awful, and eventually they're just going to have an inability to speak and eventually respiratory distress. The diaphragm's not working. You're going to get this from the water. There's fecal oral transmission, and it's just going to be lower motor neuron symptoms because it's destroying the anterior horn like cell bodies. And you can detect this, if you see like white blood cells or proteins or just literally straight up the virus. If you do a lumbar puncture and check the CSF, that can help make the diagnosis. Spinal muscular atrophy. So it's called floppy baby syndrome, and it's actually quite similar. You're gonna have lower motor neuron symptoms. So remember that lower motor neuron is the floppy flaccid paralysis, right? Because there's just because normally the lower motor neuron wants to flex the muscle, and it's the brain that's stopping it. But if I can't even, the lower motor neuron injury means that the lower motor innervation doesn't even reach the muscle, then there's just no muscle action other than a couple of silly little fasciculations, nothing. That's why you get these floppy babies, for lack of a better word. And is probably going to be diagnosed very early. It's related to the SMN1 mutation, which is a small nucleoribonucleoprotein. I have no idea what it does. Friedreich ataxia. This one's a little complicated. I think it's a little bit of upper motor neuron, a little bit of lower motor neuron, but in all honesty, I'm just not too sure. So a couple things to know though. trinucleotide repeat expansion, like Huntington's. So this is very high yield, important to know. The frataxin protein is going to help with iron metabolism, and if this is going awry, then you're going to be extra susceptible to oxidative stress. Cardiomyopathy, so HCM, hypertrophic cardiomyopathy, you might just have somebody drop dead in like their 15s, 20s, or whatever. Areflexia, so again, this would be a sign of a lower motor neuron injury, but they're also supposed to have a spastic paralysis, which is a sign of an upper motor neuron injury. So I'm not exactly sure what to make of that. So they have ataxia, and that is because the spinocerebellar region, this is actually a fourth one that we're not really talking about so much, but spinocerebellar is going to the cerebellum. Cerebellum is for gait, and that's where we get the gait and ataxia issues, hence the name ataxia. They have scoliosis, and they have this kind of like large arch to the foot, which we also see in Charcot-Marie. I think it's Charcot-Marie. And they get diabetes as well. Vitamin B12 deficiency, also known as subacute combined degeneration, at least when it's affecting the spinal cord, it can also affect the peripheral nervous system. So we mentioned earlier that B9 is folate, you take it if you're pregnant. B9, B12 kind of work in union, though, to help methylate things. So why is this one different? So B9, you run out of B9 quickly, especially if you're pregnant. But for B12, for the most part, you have like tons. You have years of stores of B12. But if you have a really, really, really strict vegan diet, B12 is one of the few nutrients that you cannot get from a vegan diet. You'd have to take supplements. So if someone's a really strict vegan, not like on Christmas I had some ham, they're really strict, this could be an issue. More likely, they have pernicious anemia, where you get autoimmune destruction of the parietal cells, which make intrinsic factor. Intrinsic factor is necessary to bind to vitamin B12 to help it be reabsorbed in the small intestine. Or if you let's say you get gastric bypass or something, or you have Crohn's disease or ulcerative colitis, then you're going to have issues of absorption. And so that's going to kind of be similar to B, is that you can't absorb B12, even if you do have intrinsic factor, because the small intestine's all screwed up. It's necessary to make, uracil and thiamine for division, but also to turn ethanolamine into choline. We need choline and myelin. That is one of the reasons that it's going to affect the spinal cord. We're going to have a demyelination of it. It's going to affect the corticospinal tract, so there's going to be some upper motor neuron symptoms, the dorsal column, so fine touch vibration, and then the spinocerebellar tract, you're going to have ataxia. Also causes megaloblastic anemia and these hyper-segmented neutrophils as well. Tabes dorsalis, so this is just tertiary syphilis. So you get syphilis, and it just, the disease progresses and evolves over the years and decades. So this is tertiary syphilis, also known as neurosyphilis. It's going to demyelinate the dorsal column. So proprioception, fine touch, way thrown off. And the Romberg is a great way to diagnose this. So Romberg, remember, is just, we just have somebody stand. All right, can you just stand normally? Remember, there's three things to come in with standing and coordination of like the trunk. And that is vestibular inputs, that is the eyes with vision, and that is the proprioception from the dorsal column. And you need 2 out of these 3 to work. Let's say you close your eyes. Well, you or me, assuming that we're fine, we're not going to lean over. We should be completely fine because we took away vision, but we still have proprioception. We still have the vestibular system. But if your dorsal column is not working, you have advanced syphilis. Then when you close your eyes, you are now taking away the proprioception aspect, and you've closed your eyes, you're taking away the vision aspect, and you have these 3 things. You need 2 out of the 3, and all you've got left is the vestibular system. That is not enough. You're going to start teetering, and you might fall over. The doctor might even push you and really cause you to fall over. So that's how the Romberg works. Very important to know that. For whatever reason, this also affects the Edinger-Westphal nucleus. So your pupils will not respond to light. So I shine a light in your eye and there will be no constriction of the pupil. However, that is a different system, a different reflex arc than if I bring my finger close to your face and you track it, and then your pupils are going to constrict. So this is called light near dissociation, where you do not constrict to light because the Edinger-Westphal nucleus is destroyed, but the different pathway that I'm not familiar with still allows you to constrict for the near like accommodation reflex. And again, I don't know exactly why tabes dorsalis affects the Edinger-Westphal nucleus, but it does. You also have lots of pain, and we mentioned these right over here. Okay, anterior spinal artery stroke, not to be confused with these two PCAs over here. This is mostly going to be the spinothalamic tract, although it's going to hit the corticospinal tract a little bit as well. So if you have a stroke of the vertebrae, remember the vertebrae are going to feed off to make this anterior spinal artery. It could just literally be a stroke of the ASA, or maybe an aortic aneurysm repair is going to leak blood and compress this and cause damage there. So at the level of the lesion, we're always going to have lower motor neuron because we're actually damaging these anterior spinal cell bodies. But below this, we're just affecting the tracts, which means the cell bodies are still fine and they're going to be unregulated, no inhibition from the cortex, and they're going to fire like crazy. So everything is up in the upper motor neuron. That's going to be below the lesion. So high tone, high reflexes, etc. So we're going to lose on the contralateral side the pain and temperature. But again, it might be the same we saw with the syringomelia. Might be like a level or two below because of Lissauer's tract for the spinothalamic. You could, if you're in the mid-thoracic area, actually be spared because you have collateral circulation from some random artery called the artery of Adam Kiewicz. I'm sure I'm pronouncing that incorrectly. All right, syringomyelia associated with Chiari type 1, the less severe one. So things want to cross the anterior white commissure. This is mostly going to be in the thoracic region. And so that's why you get a cape-like distribution, right? Because it's in the thoracic region, and it's just affecting the, what crosses over here, which is the spinothalamic tract, which is just pain and temperature. So you have this cape-like distribution where you can't feel any pain and temperature. Why doesn't it go all the way down? Because it's just this large cyst that just goes right there, and it's just in the center. So depending how big the cyst is, it could go from, T1 to T3, or if it's bigger, go from T1 to T5. And remember that if it gets really, really, really big, it could also hit the lateral horns and cause a Horner's syndrome where the sympathetic innervation is lost. Cauda equina, so very severe back pain. And recall that these nerve cords are actually these are downstream of the anterior like the ventral horn cell bodies. So these are the lower motor neurons that we're actually talking about. They're bundles of them going from the spinal cord to the muscles. So we get severe back pain, but you're going to have the lower extremity first it's going to be lower extremity reflexes because this happens after like L1 and L2. So it's going to be, the L1 to L5 is going to be the anterior part of the leg, and then the S is going to be the posterior part of the leg and like the genitals and the perianal region. But we're going to have lower, I don't know if it says this here, this is important, we're going to have lower motor neuron issues specifically. And so there's weakness and sexual dysfunction, urinary incontinence, and perianal pain, probably, not a question mark. And yeah, cool. There you go.